Hello, I'm Dr. Hagop Kantarjian from the Leukemia Department at MD Anderson Cancer Center, and it's my honor and pleasure to interview Dr. Charles Craddock. Dr. Craddock is very well known all over the world. He's now leading the acute myeloid leukemia studies in the United Kingdom, and he's been in the field for a long time. So I thought maybe we could get from him his perspective on the history of acute myeloid leukemia, the start in the 1960s, and where we are today. So Charlie, thank you very much for taking the time to interview. You've been in the field for a long time, so just let us know how you experienced the evolution of AML research and where are we today and what are the things that excite you.
Well, thank you, Hagop, and thank you for inviting me to speak at what has been an exceptional SOHO meeting, where many of the recent advances in the management of acute myeloid leukemia have been discussed. I think what we've seen over the last 50 years really has been incremental progress, but what we can see now is a wave, a tide of new therapeutics breaking. But if we just look back on previous decades, starting from the introduction of 3+7 as intensive chemotherapy, we can see how there have been incremental advances. I can think of important advances made using Mylotarg, gemtuzumab ozogamicin. I can think of really quite dramatic improvements, in fact, in the management of acute promyelocytic leukemia. And one can also see 30 years ago, the introduction of allogeneic stem cell transplantation as a curative modality in high-risk disease. We may talk about that a little bit later. But I think more recently, what's changing the field, first of all, is a profound understanding of the biology of disease, so we can identify druggable targets. Also, we have now the ability at diagnosis to have molecular classification of disease abnormalities, and that's informed the ELN 2022 classification, which allows us to identify patients with inherently better risk disease. It's called good risk disease. It's never good risk, it's better risk disease, such as patients with an isolated NPM1 abnormality or a CBF abnormality, in whom intensive chemotherapy is likely to deliver a good prospect of long-term survival. We can understand also that there is a group of patients with adverse risk disease, either based on adverse cytogenetics or the presence of abnormalities in genes such as p53, ASXL1, which can be determined very rapidly on next-generation sequencing at diagnosis. And in those patients, we need to be thinking about using transplantation, either alone or in combination with other therapies. And in the middle, we have a rather heterogeneous population of patients, but one good example would be people with FLT3 mutated AML, where the use of FLT3 inhibitors now is standard of care. So I would say, Hagop, if we look at what's happened in the last 50 years, is remarkable progress, but still an enormous amount to be done. And it would be useful to perhaps reflect on what the future might hold.
So tell us a little bit about the targeted therapies. You mentioned the FLT3 inhibitors. Are there other targeted therapies that you're working on and which seem to be promising?
Yeah, so I think probably the breakthrough medication in the last 5 years has been based on work from your group, underpinned by the results of the VRLA trial, showing that venetoclax, a BCL2 inhibitor, in conjunction with a hypermethylating agent, gives a much higher CR rate and improves overall survival in older patients not fit for intensive chemotherapy. So that in itself is a significant advance, and of course your group is leading the idea of using triplets to improve outcome in that older population. I think what's particularly interesting in younger patients is to think how we can learn from the remarkable impact of venetoclax in older patients, about how we might use a targeted therapy such as venetoclax in conjunction with other targeted therapies to deliver curative therapies in younger patients. Let me just give you a couple of examples which I think are so exciting. So the first is the work from Naval Dava and your colleagues in which you have been shown that a triplet with a FLT3 inhibitor, either quizartinib or gilteritinib in conjunction with venetoclax and azacitidine, gives very high CR rates with modest attendant toxicity and can be used potentially to displace intensive chemotherapy as a bridge to transplant. So we're hoping to work with your team to do randomized studies asking whether such triplets can supplant intensive chemotherapy. So I think that's a really exciting piece of work. And then the other area where I think there is so much promise is the possibility that one can use venetoclax in combination with other agents such as cladribine to get a high CR rate, allowing you to take older, fit adults for whom an allogeneic transplant is the only curative therapy, but using this less intensive regimen with plausibly a higher CR rate, again, as a bridge to transplant. And that's another randomized study that the UK group has the honor to be doing in collaboration with the MD Anderson. So that allows us to think about how we use targeted therapies to get to people to curative transplant. And then the other really exciting question is, how do you improve the outcome of transplant? So I think in and of itself, it's very plausible that using induction regimens such as cladribine, venetoclax-based regimen may actually improve transplant outcome. There may be less transplant-related mortality. You may have a higher rate of MRD negativity. But the other emerging opportunity, of course, is to use maintenance therapy post-transplant. And I think the results of the Morpho trial, many people call it a negative study, I actually think it was a positive study, because in a predefined subset, those with pre-transplant MRD positivity, there was a clear survival advantage using maintenance with a FLT3 inhibitor, gilteritinib. And I think that sets the stage for us thinking about how do we use either pharmacological or possibly cellular maintenance therapy to prevent relapse post-transplant.
So let me ask you, you mentioned two targeted therapies, venetoclax and the FLT3 inhibitors. There's a lot of noise about menin inhibitors for KMT2A rearranged AML, and also a lot of noise about the IDH inhibitors. So if we look at the menin inhibitors, what are your thoughts about them, and will they be restricted to KMT2A rearranged AML, or can we find a bigger potential AML population to help?
Yes, I think at the moment the data using a number of members of this class that's been published, which is phase 1/2 in relapse refractory populations, is pretty encouraging. You're seeing response rates of between 40 and 60% in high-risk patients, pretty good tolerability. There is some issue around tumor lysis syndrome, but it's mostly manageable. There's a QT signal with one of them. But you can see that this is going to be a well-tolerated salvage therapy, allowing patients to go to a curative transplant. But I think the really interesting question is whether we can move them up front. Whether you can move them up front in the non-intensive setting, using a triplet with venetoclax and azacitidine. And such randomized studies are being proposed. And in fact, I believe Dr. Issa at your institution has got some really exciting data with Ven/Aza and a menin inhibitor in older, unfit patients. He showed the data yesterday, extremely high CR rates. And then the other opportunity we have is in fit patients, whether you can combine it. And I can see at least a target population of patients with NPM1 mutated AML and KMT2A.
And how about the IDH inhibitors? Will they just replace venetoclax in combination with hypomethylating agents, or would they add to the benefit of the couplet? Is that known, or do we have to wait?
So certainly the Agile data would support that at the moment. There's reasons in terms of better response rates and actually better tolerability to use them with a hypomethylating agent in preference to Ven/Aza. But I think actually what is going to change the field again is the triplet data. And Dr. Lashkovitz, who works with Dr. Donato, has published, they're small numbers, but they're very promising, of a triplet with an IDH inhibitor and Ven/Aza of getting very high CR/CRi rates. So again, I think there's going to be really important randomized studies in the younger but also older populations, comparing that with Ven/Aza in the older patients and with intensive chemotherapy in the younger patients.
So you mentioned several times allogeneic transplant. It seems very dear to your heart. Tell us what you're doing in transplant that could help more in the UK, and also is there a way of avoiding allogeneic transplant and still getting high cure rates in acute myeloid leukemia?
Yeah, so to deal with the first question, I've always found it rather extraordinary that at meetings such as this, we spend appropriately a lot of time talking about advances in pharmacological interventions, where the response rates are sometimes modest, but certainly the duration of response is not long. In contrast, we spend relatively little time either talking about how we logically integrate allogeneic transplant, which has such an effective curative benefit, or even more importantly, thinking through randomized trials about how we might more effectively deploy this potent antileukemic effect. So let me just give you a couple of bits of evidence that makes me so excited about transplant, and then secondly about where we might go. So I think we sometimes underestimate the compelling data of the last 15 years to show how strong the antileukemic effect is in patients in CR1 who go to an allograft. And I'm struck always by the data from the HOVON group, who took patients with AML in CR1 and compared the risk of relapse in patients who just continued with chemotherapy or patients who went to have a transplant. The hazard ratio for relapse for people who went to transplant was 0.33. That's almost a 70% reduction in relapse. So that's very striking effect. And also there's evidence from a number of groups, including ours, that actually by manipulating the intensity post-transplant immunosuppression makes a 40% difference in relapse risk. So let's just recognize we've got a very powerful anti-leukemic effect. And if it was a drug, we'd be thinking much more ambitiously about it. So that's land that with you first. And then I think the second question is, how could we, first of all, increase the number of patients who can come to transplant? So there's accumulating data from the CIBMTR, another group, that in fact you can take fit adults over 70 to transplant safely with good effect. So the number of patients who are allowed to take to transplant now is increasing because of the advent of reduced intensity regimens and better GVHD prophylaxis. But most importantly and ethically, because we, using post-transplant cyclophosphamide, can use mismatched, unrelated donors safely, therefore creating a situation where almost every patient, regardless of their ethnic background, has a donor. So transplant now is much more deliverable, and I think there are real opportunities for us to think more carefully about what's the best conditioning regimen, but more excitingly, about how do you maximize that graft versus leukemia effect. And if you wanted me to put my money on two of the most exciting areas, one would be to think about introducing other targeted therapies, such as menin inhibitors, as post-transplant maintenance, but also to think about randomized studies using donor lymphocyte effusion, which is so effective. And you're right, Hagop, we should be taking more patients to transplant. We can do that. But also, as we have more effective induction regimens, plausibly using venetoclax or other targeted agents, we are going to have deeper remissions and some patients who simply don't need to come to transplant. And probably the most informative data guiding on that will be, firstly, understanding the genomics at diagnosis, but secondly, detailed assessment of their response to therapy using next-generation sequencing, MRD.
So you mentioned DLIs, and I want briefly your thought on this. So you're talking about DLIs post-transplant as one form of maintenance, one DLI, multiple DLIs. What are your thoughts on this?
Yeah, well, the UK has just closed out, actually, about a year and a half ago, a randomized study of about 160 patients, where we asked that very simple question. We had a schedule of 3 DLIs to be given at low dose escalating in patients who were off immunosuppression. That was a randomized study. It's closed out. We'll have the results soon. So to the point, one is, does DLI of any sort show benefit? The second is, what should be the dose? The third is, what should be the frequency of administration? If this was a drug, we would expect those randomized studies to be done before we deployed the agent in the clinic. And the transplant community have, for some reason, lost the plot in previous years and not delivered these simple studies. Now, the US CTN, bone marrow transplant CTN, led by Mary Horowitz, really has been an inspiration example of how the transplant community can come together and deliver pivotal studies. We think of the paper in the New England Journal of Medicine showing the benefit of post-transplant cyclophosphamide in a randomized study. And the UK Impact Group, which I and my colleagues lead, has now randomized 1,000 patients to pivotal randomized studies answering those questions in transplant. So I would be really issuing a rallying cry to the transplant community, is we have to learn from our colleagues in the leukemia units who deliver such important randomized studies so effectively and do the same in transplant, and try to understand how do we integrate transplant with upfront intensive chemo.
Thank you very much, Dr. Craddock. This was very educational, a wonderful discussion. I hope we learned a lot and will apply at least some of that discussion to our practice in acute myeloid leukemia. Thank you very much.
It's been a great privilege, and thank you for organizing such an amazingly interactive and fresh meeting.
Thank you.